Welcome everybody to the first Council of Governors meeting of 2025. I hope you got a break over the festive season and a happy new year. Apologies for absence for today's meeting. We have from Councillor Linda Chambers, Alex Weeks, Will Taylor, Sharon Nobbs and Tim Durkin, Philip Earnshaw and Dean Royals. I haven't had any other apologies unless anybody goes from someone else. Nope. Okay, thank you very much. First of all, can we do the minutes of the meeting held on the 16th of October? First of all, can direct declarations of interest first. If there's any conflict of interest, if colleagues could let us know now. And if you've got any changes, please let the board support unit be updated with those changes. Any conflicts from anybody? No, thank you very much. On to the minutes then, and I think Ted, if you're there, you had a correction to the minutes. Ted?
Yes.
Thank you.
Technology here. Yes, yes. The minutes. Sorry, can everybody?
Okay.
I'm having trouble as well. On the minute.
I'll tell you what, if you want to come back, are you okay?
Yeah, I'm gonna come back. The minutes have confused me.
Ted, didn't you say before, I think, to me that there was a mix-up of names between yourself and Tim Durkin that you needed to get changed? And if that's the case, if you're having problems, I'll take that away and we'll make sure that's corrected in the minutes and we can sort it out via email, the detail. Is that okay?
I didn't tell you, so I'm getting a job to go on it. I am going to try and come back again. Okay.
Okay. Any other corrections to the minutes? And if Ted comes back, we'll take that. But I think basically it was a wrong person's name put against a comment. Any other corrections to the minutes? No. Okay, then subject to that amendment by Ted, are you happy to approve the minutes? Thank you very much. Minutes of the annual members meeting. Any corrections to those minutes? No. Okay, thank you very much. Are they approved? Yes. Obviously, they'll go back to the annual members meeting next year as well. On the action log, a couple of issues. Firstly, action under 12/24, results of the membership, that has completely happened. It is closed. It has been completed. It was taken off and somehow it's reappeared back on. I don't know why. I mean, gremlins in the system, but it's all happened. And in fact, I think the Engaging Members Group also had a discussion around the membership as well. Stella, I think that's the case, isn't it? Yeah, so that can be removed. On the first action on the action log, Katie got in touch with all governors to ask about if you had certain areas of interest. I don't think there's been a huge response. So maybe, Katie, you could do a lovely, kind, encouraging reminder. And obviously, we've got new governors coming on as well, so it would be opportune to do that as well. But if you can let us know if you've got particular areas of our services that you're interested in, I think that's just helpful for us to know. That would be really super helpful. I can see Kimberly. Hiya.
Hi, I've not seen that email. I don't know if it could be sent out again, please.
Sure.
Just so I can have a look at it. Thank you.
Sure. Marilyn? You're on mute, Marilyn. Thank you.
We were having a conversation earlier about this, and people were saying that they felt like they couldn't actually say as much as they wanted to say because they didn't know a lot of what the interest groups were within the trust. So is it possible for us to get a list of all the different departments within the trust?
Yeah, I mean, all that you can, and I think they are in the Governor information pack, but also obviously they're available on the website as well. But I mean, I'm sure we can extract something and send you the full list through. But they are all on the website, and I think they're all in the Governor Information Pack too, from what I remember. But I can check on that. But yeah, we'll take it away. But linked to what Kimberly said, we'll do a reminder, a gentle reminder to everyone about it. Brian.
Yes, I just wanted to reinforce Marilyn's point, and I have looked on the website, and it's difficult to get a feel of all the services that the Trust provides, and I think there is something to be said for having just a list of all the services in a written format, just so that the governors and new governors would know exactly what the services we provide are. Okay, thank you, Brian. We'll follow that up. Tony?
Hi, everyone. It seems apt just to mention about governors' interests. We've had several discussions about visits, and I think I don't know if the list is out yet or it's out soon, but I think one or two governors have ideas about where they'd like to visit as well, which may not be on the list. So if it's okay, once we see the list, we'll share with you our ideas as well. And I think these are focused on areas of interest, for example, primary care. Just one example, if that's okay with you.
Yeah, let me take that away. I mean, obviously the board governor visits are sort of knowledge visits for services. So let me take that away and just the other thing that I've been talking, actually Michelle and I had a conversation about, is every year there are, and this comes under Pete's area, there are place visits which are involved in looking, for example, the environment, the food that's provided, and all of this. And I understand in the past, governors, can't have every governor on it, but along with service users and others, governors sometimes took part in some of those as well. So we're looking at if there are some governors who are interested in that particular area of visiting services and seeing what they're provided as well. Let me take it away, and we'll make sure we follow up, and we'll email back to everybody where we are on all that. Is that okay?
Yeah, and we'll do our part through the engaging with members group to encourage governors to visit as well, if that makes sense.
Yeah, I mean the visits have to be sort of organised, and obviously it's difficult, because actually it's important that that's happened. But let's make sure we sort of have the process clear for 2025 for everybody, and then I'm sure that will be helpful. But
thank you. That's good.
You're welcome.
Thanks.
You're welcome, Michelle.
Yeah, if you don't have a look, Tony, I mean, obviously any engagement with members that are asking you to visit would be quite helpful. Just to have a direct email about that, Tony. It'd be quite interesting to see what members are requesting and the reasons why, to be fair. Just to reiterate that it's not part of obviously the governor role to do visits. It's something that we obviously encourage as an organisational point of view, because we do think it's useful for the governor. Obviously, we've just been talking about services and what services we provide. We do feel that it builds on obviously the presentation we're just going to have about beginning to understand some of the services that we use. But we have to, but we'll have a look at those if you let us know. But anything from a membership point of view that you're thinking you want to visit, then we'd like to know a bit sooner than that, Tony. If we could, that'd be really helpful.
Great. Thank you, Michelle. Okay. Anything else on the actions log, work plan, or no? Okay, fine. Thank you very much. Okay, I'm really delighted to have Becky Whisker with us today, and we're going to have about 20 minutes with a chance for questions as well, to have a spotlight on developments for the community forensics service that we provide. So Becky, you're very welcome. We've not met before, so it's great to see you and have you with us today. Thank you.
Yes, I'm excited to be here, excited to talk to you all today. I'm just going to set up sharing my screens and make sure that you can see. That's not going to work. Sorry, 1 second. And
there we are. I think it's coming. Ta-da.
And just setting it to screen. Oh, that's not the right screen, is it? Can you see the beginning slide, or can you see the bit with the black outline?
Black outline.
The black outline. You just...
Okay. 1 second.
If you go back to that page, page, Becky, that you just had up, then there's right at the bottom, in the bottom menu, there's a full screen icon.
Yeah, I think you just do that.
That'll work.
Thanks, Jackie.
There's a few different ways of doing it, but I think you can probably. Oh, we've got your calendar now.
Yeah. Goodness, sorry. Sorry, just 1 second. Don't quite know what I've done there because. I think I've managed to close it all together. Sorry.
All right. Don't worry.
If you can help me sharing it. I've already shared it with Katie.
Katie, could you help share that, please?
Yeah, I'm just opening it up. 1 moment.
Sorry, I don't know if I've changed my settings since I last.
Can you all see it?
Yeah.
Is there a thing at the bottom of that where you can just expand it so then you lose the sort of bump around it?
That's it.
Nope.
Nope. On my screen, all I can see is the.
You need to change the view, I think.
If you could go to slideshow normally, that's what I was doing. So I don't know if I'm advising you to do what I did.
No, I think we might. I think
on the top menu bar.
You press slideshow and from the start.
Katie?
Yeah.
If you're having problems, Katie, if you want to send it to me, I'll try and load it.
Is that it?
Hang on. We're not seeing anything yet, Katie.
Right, I'll send it to Stella. 1 moment.
I'll just introduce myself.
I'll tell you what, Becky, why don't you just start and then we can always get the slides later, because I think people are really interested in hearing from you, to be honest.
Absolutely. So
and then we'll send the slides out later. Thank you.
Introduce myself first and hopefully we'll get caught up there. So my name's Becky Whisker. I work within the forensic division. I've worked in Humber for 4 years. I've worked in the region for a lot longer. So I've got over 20 years forensic experience, and it is quite a specialist interest. I get very excited about it. So if I get carried away, to bring me back, some of it can get a little bit detailed. So thinking about who we are in the team, we are a multidisciplinary team. I'll go into, on one of the slides, I'll go into some detail about who the personnel are within the team. Our practitioners have a specialist interest and skills in terms of risk assessment and risk management in working with patients in the community who might present a risk in terms of their offending and also in terms of their psychiatric presentation. So we, as a community forensic team, sit within the wider forensic division. We're an integral part of the forensic division. We physically sit in the office spaces in Humber Centre, and that really helps us to work with the inpatient units to try to bring patients to a safe and effective discharge sooner. A lot of our work, we don't see patients at the Humber Centre, so we really make sure that our community patients have a community focus, so we're not bringing them back into an inpatient environment for therapeutic sessions. We see patients out in the community, and for what we do, our broad remit of what we do is we provide specialist forensic advice and assessment and intervention. So some of that first slide will become clear as we go on. If you just want to move on to the next slide. Thank you for sorting that. So who meet the multidisciplinary team? Who are we? Well, that's me in the top left-hand corner as the community clinical lead, and I work closely with our psychology leads who are specialists. One of the specialists is in learning disability and autism, and the other in mental illness and personality disorder. And then we have a consultant psychiatrist working with the team, and we have our operational managers and I work in very close partnership with our operational manager, and we've got a deputy kind of operational manager as well as our specialist forensic practitioners. So who are they? They tend to be from a professional background such as social work, occupational therapy. We've got learning disability nurses as well as mental illness, mental health nurses as well. And we have a whole team of dedicated social workers who work alongside us. And then our administrators as well are really integral into our team and do a very good job of making sure all of our referrals and information is sorted for us. So just moving on to the next slide, what do we do and how do we do it? We have a tiered level of approach. So we have a single point of access team who help to signpost where we receive referrals we think might not be appropriate. We still offer an opinion. We still help the referrers to understand, well, if it's not for us, where might they go? So some of our advice, for example, might be to make a referral to our MAPA partners or talk with probation or the police, and that signposting takes account of immediate safeguarding and safety advice. And then the next part of our model, I always imagine it, I'll talk to our team about it being an inverted triangle. So most of our referrals we work with at a consultation level. So you might be working with a patient in a community mental health team and a bit worried about somebody's risk, and you might ask us for an opinion. We'd come on, we'd meet with the referrer, we'd understand the nature of those concerns, a little bit more about the patient, and think about what would be needed to support the patient, but also support the referrer. And thanks, Lynn, for that addition there. So the consultation model takes us between 4 to 6 weeks. So we say we will meet with the referrer within a week of receiving it. We will offer you a written consultation report, so you've physically got something in your hand that you can refer to with some recommendations. But if we were a little bit more worried and wanting to do a little bit more support, we'd move into the next stage of our model. So that the consultation being most of our referrals, fewer of those referrals would then move into an assessment element. And that's where people might be, referrers and the service user themselves, a bit confused about their risk, why things are happening, why they feel a certain way, why they're presenting that level of risk. So we'd help to do what's called a structured judgment risk assessment. It's a very detailed specialist assessment looking specifically at risk, and we'd work with referrers to see then, this is our assessment. Can you work with the outcomes of that risk, or do you need some specialist intervention from us? So we'd go out and we'd do intervention with the team who were already holding the service user. And we don't just swoop in and take the service users off onto our caseload, because for continuity, that's not what service users need. So we would always have an emphasis on working with in the first instance. But then there is a very thin, very small cohort of patients whose risks are so significant and their needs are so great that actually what they need is specialist care coordination from specialist forensic practitioners. So we do work with 38 patients in the community, are care coordinated. But we can see that breakdown of numbers if we move on to the next slide. So why am I talking about this like this is news? Well, it's been a really fast pace of change in forensic world. Like I say, I've worked in forensics for over 20 years, but all of this change has come since 2017. So largely, though not wholly, our inpatient wards are doing what they were doing when I qualified in 99. So, you know, some of those wards that were around in 99 are still there doing those roles now, but a lot's changed within what goes on wards and what interventions are offered, but also the flow has changed. So I can certainly remember forensic patients spending 20, 30 years in secure hospitals, and that being the standard, the norm, and that once patients entered into those settings, found it very difficult to move on and move into the community. In 2017, we started to think a bit more about that flow, and we did have very small community teams back then for the few patients who did come into the community. But there was a big project called SCFT that was piloted across the nation, and we worked those SCFT pilot projects, went in and intensively worked with all of the patients who were in those settings to see who could come out into the community. So in Humber, we had one of the highest rates of repatriating those patients back into the community. And essentially, we did a brilliant job at getting everybody back into the community who could safely be brought back into the community. So it's not that many years ago, we went from having a very static community caseload of 12 to now in the last 12 months, we've supported over 140 service users. So again, for some of you big community teams, 140 isn't very much, but in this world, that's a really big change. So just to give you a snapshot of today, our current clinical caseload is we're working with 5 patients on a consultation basis. 5 of them were offering specialist assessments, 17 patients we're doing an intervention with, and we've got 38 patients who are care coordinated. So the data differs a lot month on month, depending on which patients have discharged, but as a whole, we have, for this locality, reduced length of stay by 21%. So that means for a service user, they can expect to spend much less time in a secure hospital and much more time safely integrating into the community. So if we just move on to the next slide. So what are we doing well and what are we excited about? Well, lots. We have got a very low return rate. So you would think that if we'd done all of this repatriating patients from secure care, that might not always go well. But we've currently only had 3 of our patients go back to secure care. And that's not to say that our patients haven't required hospital care, but it hasn't been deemed as them requiring that return back to secure care, which is good because in large, if you go to secure care, it takes you quite a long time to be discharged, but also it's a very expensive, intensive resource. And it might be that you're having more of a blip and need a shorter period of admission. So we have recognised that having more patients out of secure care impacts on other services as well. So we do consultations and we do training to other teams and other parts of the division, but also outside of health as well. So we do work with quite a lot of the accommodation providers. We in our team have got a really good workforce retention rate. We're really pleased about that. A lot of our team love what they do and they're interested, and they've had a lot of change. So that is difficult for teams. We recognise that, but by and large, the team are really positive about that and really interested in the future. So we're thinking more now. We've settled down a little bit on that change. Have we got our workforce right? Do our service users need different things from us now they've been in the community for a little while? We triage all referrals from prison and from secure care. So that means our partners in CMHTs aren't getting referrals from these environments without them having seen us first. And we've fostered really positive relationships with other agencies in the community, some of which I've mentioned already. But we work really closely with our partners or with these service users. Some of our patients have been in secure care for a long time, and some of them have really high levels of risk. So we have to be pretty creative about our discharge pathways, and we are in a position to offer some really intensive packages of support. So sometimes if our patients are in crisis or they're new into the community, we will offer things like daily visits and weekly MDT forums. And we won't be looking to offer that long term, but we can flex to the needs of patients. Just move on to the next slide. So we do have some challenges, as you might expect, with that rate of change and this changing culture, I think, for the whole forensic pathways. There isn't an agreed national standard, national specification, but actually regionally we've suggested one, and NHSE have supported that and told us to, yes, we agree with you, get on and deliver that. Well, everybody else catches up. So we're very pleased to be working with commissioners on the delivery of our model. It is a bit of a challenge to deliver this across Humber and North Yorkshire, because as I'm sure you are aware, there's lots of differences across Humber and North Yorkshire, lots of richness in that region, but we have social enterprises, we have other trusts and different expectations, and so we try to make sure that we locally are delivering an equitable service for service users. So we might not always deliver the exact same, but we want to make sure our service user experience is the same. So we have lots of meetings with our other providers to think about what are our quality standards and are we adhering to those, and what else can we offer and what needs to change. So lots of meetings with partners to make sure that we're trying to be as similar as we can. I think sometimes this is a challenge, that there's the stage of our service development is that we are somewhat ahead of other areas. Now, it depends what day of the week you're talking to me. Some days I'm excited about that and feel that we're really leading the way and feel really positive about that. And I can speak, I think it'd be important in this forum to let you know that I, in this trust, have felt that executive members have been very supportive of an autonomous practice. So I felt very supported to do my role, to be dynamic, to meet the needs of service users in a very autonomous way. But as you can imagine, sometimes that it would be a benefit if other areas were at a similar stage, so we could share a bit more. So I am meeting with Merseyside, actually, who seem to be catching us up a bit. So it'd be interesting to see where they're at.
Okay, Becky, can I just take a question from Kimberly, if that's okay?
Sorry,
She's got a hand up. Thank you.
Hi, sorry, let me just try and get my computer to work. 1 second, it's now decided not to work. Hi, I just wanted to ask, you mentioned earlier about training sort of outside agencies and housing to support these individuals who've been released into the community who might still need support. Is there any support in regards to training for like people like ourselves who work in, like parliamentary staff and things like that? Because we are council staff who tend to have these people email them on a regular basis.
We haven't to date, but we're like I say, we're a very kind of dynamic service. We're very new. We're very open to requests, and we absolutely have the capacity in our current specification to do that. So
thank you. If I put my email here, would you be able to drop me an email and just something I can discuss, because it's something we're finding more and more on a regular basis, that we're getting quite a lot of concerning emails to our email address at Parliamentary Office, and they're not being able to support those people. So it'd be really good just to sort of look if there's any training available for us, because it can be quite distressing for some staff members.
Yes, absolutely.
Sometimes. Thank you.
Yeah, thank you. So sometimes we struggle, at this last point on this slide, we struggle a little bit to determine what is a forensic patient. So sometimes we'll find that that word has perhaps leaked out of its original meaning. So people will have, maybe referrers will have an understanding that a patient is forensic, and that might not be a shared view from forensic services. So try to perhaps understand a little bit more about why the referrer feels that this patient has a forensic need, but also recognise, I think as you've just said there, Kimberly, that there's a degree of anxiety and concern caused, and that's what's most important, rather than labelling a patient. It's about supporting the systems around that patient to quantify the risk and to think about how we might be working with that. So where are we now? I think that's the next slide. So we had a couple of different community teams and we've aligned them under one. And so it's September 2024. We tried to draw a line under some of our confusing titles, and we're now, regardless, called the Community Forensic Team. All of our referrals go through our single point of access, which is almost another presentation in itself. So I also lead our single point of access, which is also a national clinical first. We are the only clinically led single point of access for forensic referrals in the country. I'm presenting to the national quality teams next week about that. We're very interested in our success with that. We've increased our clinical support, so we have subcontracted teams in Navigo, Ardash and Care Plus Group. I certainly go out every couple of months to each provider. We offer them as well some specialist support in terms of their supervision and guidance, because they are smaller teams than we have here in Hull. We've directly impacted on a reduction in admissions to forensic inpatient beds, and also our patients, once in beds, spend a lot less time in those beds. And along with that, as I've already demonstrated, we've got a reduction in that part of the pathway in inpatients, and so consequently an increase in our community caseload, which is absolutely what we want to see. The next few slides, actually, I will just leave you to read at your leisure, because they are bits about bits of feedback that we've got both from service users and from other providers that we work with. So wanted to share those with you, but we probably don't need to go through those in detail, and wanted to spend the time just opening the floor to questions, if that's okay. Or over to the floor.
Thanks very much, Becky. Really welcome that. And just to flag as well at this point, we have got a sort of deep dive into the services we provide under the Humber Prison contracts and services, and that's in the programme. It's in my report for July, where we'll have more chance to look at this service and how it operates, and I suppose how it sits alongside your work as well, Becky. So Jackie, you're up first, and then I've got Emma and Steph. Jackie.
Thanks, Becky. I'm the appointed governor for the university, so you probably won't be surprised by my questions. But the first one is, I remember talking to you, I think, and some others who were involved in this change process right at the beginning. I think you had a stall at one of the AGMs. It wasn't the last one, it might have been the one before. And we had a conversation. And so you've got some great outcomes and impact here, and it's really good to hear that you're going out and talking about these with other services. Have you got any plans to publish this?
So we are working with our director for the for CPAT, for the Provider Collaborative, and she wants to help us to publish some of this alongside, so not just what's happened in the community, but what's happened in the single point of access as well.
Yeah,
because
it's really important.
Yeah,
published, isn't it?
They can't really be disentangled, but yes, we've got more than one person talking to us about that, whilst we're also trying to do the doing. But
yeah, it sounds like you're capturing that information, so it's just, you know, I was just that was an interest. And my other question is about students, because you didn't mention that in, and I know this is a very specialist service, so it might have to be a sort of hub and spoke model. I imagine you might have clinical psychology doctorate.
We do. We've got a trainee psychologist at the moment. We have student nurses, student OTs and student social workers.
Right answer.
And we do training too in the university, from psychology, from our forensic CAM service, and from social work as well. And then I also guess.
Well, brilliant. Sorry, I didn't know that. Sorry, I didn't know the answer to that, but that's good to hear. Thank you.
Thanks, Jackie. Emma.
Hi, Becky. I'm the appointed governor for voluntary sector, but I work at Mind. So I just wanted to ask you about how you're linking with the voluntary sector, because there was a lot about partnering with police and other services, but within the community, is there anything you do with voluntary sector organisations?
Yeah, so we have a really good link with Working for Health. So a lot of our service users volunteer within Working for Health, and we have good information sharing kind of protocols with them and other vocational providers. A lot of our social work input is with housing providers, but I will say that through the profile of risk for our service users, we do find accessing community projects particularly difficult. A lot of our patients present serious and significant risk to other vulnerable adults and to children, and you know, we take that risk really seriously. It does limit their access, but we have got a host of our service users working with voluntary sector. You probably need to speak to our OT lead more than me. Yeah,
great, thank you.
Thanks very much. Next we have is Steph.
Hi, thanks Becky for the presentation, really helpful. Just a couple of questions really. One is around co-production with patients and carers, both in terms of the design of the service, but the design of the outcomes for individual patients as well, where that fits with the service. My second point is just really a question about the social work team. Are they employed directly by the trust, or are they local authority social workers, and how does that link in?
Yeah. You might regret asking that question about social work.
Sorry.
It's all right. It's fine. So co-production, yeah, really important to us. We can identify for each and every patient, all the care plans are co-produced, and if they're not, then it's identified as being a service user request not to be involved at that level. Their MDTs are open for service users to join us. Not often do our service users choose to join those environments, and I think that's often because they've spent a long time in hospital, and they don't want to meet with teams, and they do want to lead a community lifestyle. We try to make those collaborative environments as accessible as possible. We've had two peer support worker roles in the community forensic team. They haven't gone particularly well for one reason or another. We've reviewed those with our engagement network, and we are re-establishing them from April onwards. Our operational managers going on some training to think about how we might facilitate those roles a little bit differently. And also the engagement network join us in our community pathway development group, which is where we're thinking about our developments. So we definitely could do better. Individually, case by case, I think we do well. That more strategic focus, I think we would say our engagement work is a little bit further behind than some of our other developments. Is that okay for that bit? So just thinking about social work, then the answer is it's mixed. So we've got two of those social workers are entirely employed to work within the community forensic team, and the other social workers are employed through the local authority contract. But how we deliver that is as one whole team. So we don't look at two individuals working with us. We look at whole time equivalents to make sure that the social workers match the need, and we're not just isolating particular staff to work on particular contracts. We're really fortunate to have the integrated social work offer. There's only us and Navigo in the region that have that integrated social work offer, and it's absolutely an asset in terms of risk management and service user experience. So we're currently the only area, Hull, which is where that exists for. Hull is the only area without any patients who are clinically delayed for discharge, and that is because of our integrated and creative offers, and we're able to tell our accommodation providers all of this fantastic support that they're going to get if they do offer our patient a place, really. So it's a real strength.
Thank you, Becky. I've got two more colleagues and then we'll bring this to a close. Stuart and then Ted.
Hi, Becky. I'm Stuart McKinnon-Evans, one of the non-executives, and I chair the Specialist Provider Collaborative Committee and hear about this service quite a lot through your colleague Steve Shaw, principally. And I'm really interested in this notion of the capacity in the community team to, for those people who are still in our secure units, who are clinically ready for discharge, and understanding what the barriers are, or rather what the capacity constraints are in the community setting. So at the last committee meeting we heard, I think we got probably 15 residents in our secure units clinically ready for discharge, but can't be discharged. Can you give us a flavour of the sort of things that might describe the capacity constraint that you're facing?
Yeah, so largely it wouldn't be our capacity. That's the problem. Though we do run close to that marker, so our capacity is 40 for care coordination, for example. So we do run close to it, but we've not really been the reason. Our direct capacity hasn't been a reason for not bringing people into the community. Often the clinically ready for discharge patients are delayed because of housing provision is the number one. And that's where we come back into my previous answer, is that it's that dual model locally is what prevents it, but in other areas they don't benefit from that. So a lot of the delays for the provider collaborative are in North Yorkshire.
Yeah. And I think it's really helpful to understand that, because we as a trust working in the wider system, we kind of need to understand really where we can help partners or influence partners to increase their capacity, which might relieve cost and burden on the NHS in a more beneficial way for taxpayer funds generally. So thank you for explaining that.
Thanks, Stuart. Ted, finally, Ted. Ted, can you unmute? Could you put your... Thank you.
Okay, is that better?
Perfect.
I'm really struggling with this technology today. Now, that was very interesting. What I would like to ask is, are you and your teams solely responsible for a geographical area, or is that shared among other teams?
So I am the community clinical lead for Hull and East Riding, and we subcontract teams in Humberside. So I am the clinical commissioning lead for teams in Care Plus Group in Grimsby and Navigo in Grimsby and Ardash in Scunthorpe. And then we work in partnership with a York-based team that offer the same service to York and North Yorkshire. I do have a little bit of insider knowledge there because I used to work in that team. So relationships are good, and it is a small network.
Thank you.
Thank you, Ted. Thank you so much, Becky. That was great. And I think from the questions and also the comments in the chat box as well, there's a sort of real interest in the work you're doing. So thank you very much for coming along today. Really appreciate it.
And I'm really happy to receive any questions outside of here. And that's great.
Perfect. Thank you so much. Have a great, rest of the week. It's Thursday, but have a good weekend then.
Thanks. See you
Thanks
later.
so much, Becky.
Thanks,
All the best to
Becky.
you,
Great job.
to you and the team. Thank you.
Great job,
yeah.
Becky. Thank you.
Okay. We'll move on quickly to my report. I'll take it as read. Are there any questions at all? I think that might be a legacy hand from Ted there. Just to say, to take this opportunity, can I just thank John, who's with us today, John Morton, and also Patrick Haag, who sadly was not re-elected as a governor, but thank you for your time and working with us. But also to Patrick Hargreaves and Sharon Nobbs, who've actually, completed their term and aren't re-standing, to thank them as well. And we could just put that in the minutes. Thank you. If there are no questions, I'll move on to the Chief Executive report. I have had some questions in from governors, some of whom can't be here today. So I'm going to sort of put them in as we get to the relevant items on the agenda. Michelle.
Yeah, thanks, Chair. I'll pick a couple as we go along, but thank you for those questions. Really, really good questions, which we'll hear about in due course. I am taking it that people have had a chance to look at the report in detail, so I won't go through it verbatim. Just as always, pick a couple of items out, but then obviously please do ask any questions. I will ask Lynn just to give us a bit of a resume, as always, on the current situation with winter pressures. because the system has been under enormous pressure and actually been at what's called OPA levels, which I think we've talked about before, been at the highest level for a sustained period of time. Partly due to capacity, partly due to acuity, and partly due to the viruses that are circulating. So I'll ask Lynn to look at that. Our services have held up really well over the Christmas period and over that those pressures, which we don't see really abating actually at the moment, but we'll come on to that. I will pick up the fact that we have now got we're developing lots of work in relationship to our leadership programme that we've talked about before, our PROUD programme, which is part of our investing in you, valuing you, our people's promise work and strategy. And it's really great that we now got that postgraduate scheme that we've launched for all our PROUD graduates, and we think we're probably one of the only organisations in the country that actually do that now. So we will have formal sessions throughout the year that will be conferences with speakers, will be development sessions and action learning sets. So lots on top of the current access to development and learning, but they will be just for the PROUD graduates. And we're still getting some fantastic feedback. We continue to get fantastic feedback about that programme. So that's really positive, and we look forward to seeing that develop specifically this year. Lots happening around the system. From an ICB point of view, mainly around finance, which Pete will touch on in his report, so I won't duplicate that now. But we are obviously still remain influential in that system, which is really good from our organisation point of view. We have developed a new mental health maternity service, which I know there's a question on, which I'll let the person ask the question and then answer the response. But that is a really positive development, and we really look forward to seeing that develop over the next few months. Lots of information there from a workforce perspective, particularly around statutory mandatory targets and where we're up to, and it remains really positive at 93.3%. Just to remind the governors, there is no national target for statutory and mandatory training. We set our own, and we have a long conversation on an annual basis in relationship to what that should be, because we continue to overperform, which is good. We make sure that we set a realistic target because we need to continue to meet the realistic target. The national average varies so much that we don't really looking at the national average because it varies so much, but we do benchmark ourselves against other organisations, and it is always better to overperform from a staff point of view rather than underperform. There's an update on the Mental Health Act bill, and as always, there's a detailed report from the communications team and health staff. Lots in the report, though. Pete will pick up quite a lot from a finance and performance point of view when we get to the relevant items. And Lynn, can I just pass you over just to give us a bit of a resume and a bit more detail on some of the winter pressures that we've been having over the last, particularly 4 or 5 weeks. Thanks, Chair.
Thank you. Thanks, Michelle. Yes, so just to pick up what Michelle's just described, unfortunately has been a very difficult winter position, particularly since just after Christmas, probably from Boxing Day onwards, due to a number of factors, particularly impacting on the acute hospitals and ambulance services. So those acute hospitals in our patch, and particularly York and Scarborough, were sort of feeling the extreme brunt of this. So the operating pressures system, the OPAL levels, have been at OPAL 4 through that period. In fact, the whole system reached OPAL 4 for short periods as well. It was due to the issues that Michelle raised, increased demand over Christmas, and particularly increased prevalence of the winter viruses, particularly flu, actually. And those patients that were admitted to hospital with flu were quite unwell as well. That led to pressures in ED where patients were waiting to be seen and definitely waiting for beds. And that led to ambulances queuing, to transfer patients to the acute hospitals. That led to increased waits for ambulances in the community as well. A very high concern around patient safety as a consequence of that as well. And those pressures sort of did continue for the following 2 weeks. They have reduced a little now, which is really good to see. And what's really positive this week is that the ambulance services are particularly reporting that they are back to sort of what they would call normal operating position for this time of year. but we have been waiting as well for the peak of the current sort of flu to be reached and reduced. Looks like that's probably happening right now as well. But it did mean, obviously, unfortunately, that elective activity had to be stopped by the acute hospitals in order that they could use all of those beds for that urgent demand as well. And obviously, it's going to take some time to recover that activity too. From our point of view, we did see increased demand, and obviously we have done everything that we can from a mental health point of view, through our mental health streaming service at Hull Royal, for example, and particularly the demand that our community services in North Yorkshire have supported with as well. So we're really making sure that we've got really good flow through our beds at Moulton and Whitby. We're still in that process of optimising our virtual ward, but I'm pleased to say that is improving as well, which is great. So we didn't impact on those system pressures, but we obviously saw the impact on our services of those. However, we did maintain that Opal 2 position through Christmas. However, our main concern was the impact of sickness absence on our staff. So we did see that rise through that period. And that led to our decision to look at our infection control interventions, and we made the decision last week to introduce mask wearing back to our inpatient services to protect our staff, and obviously in order to protect our patients as well, and make sure that we can sustain safe staffing levels. We've got that under constant review at the moment, and obviously we know our staff would prefer not to work in masks, but they understand as well why we have made that decision. We'll review it again next week, and hopefully if that peak in the flu prevalence does reduce, then obviously that will be a factor that we'll be taking into account. So it has been a really difficult time for our whole system.
Thank you, Lynn. Any other members of the EMT want to add anything in that's not already on the agenda later in here? No. Okay, so let's take some questions. Can I just on behalf of Tim Durkin just ask his question, because it's pertinent to the report, Michelle. He sent in, he said he very much welcomes the new maternal mental health service proposal, and he said that Michelle knows my views that I would like to get back to the provision some 4 to 5 decades ago at De La Pole Hospital, where there was a mother and baby bedded unit. Over the years ahead, I hope this new service will be able to be developed to include such a provision. Michelle.
Yeah, I mean, it's a really good point. I think one we'd all support and endorse, actually, especially when you look and you map the provision for mother and baby units. As you know, the nearest one for here is Leeds, and we've all had conversations both with the regional office who actually commission that particular service, and other organisations. We have got the facility to draw down some money if we do manage to secure a location. The issue we've got is the location to develop it. We'd have to build it, but it has to be near an adult inpatient unit, which is obviously our drawback at the moment, because we've looked at various configurations of our current site provision and it really doesn't work at the moment. So the idea is that when we look at our inpatient new build, which obviously we continue to do, especially now we've demolished the old HQ site, but we will probably look to see if we can do some provision on there. So it is in constant conversation with the executive team and part of our capital proposals, but obviously to develop it costs money, and as you know, access to capital is exceptionally difficult at the moment. So we are looking at different ways that we can particularly fund capital developments at the moment. So basically, yes, we're all in agreement, we need to do that. The revenue potential is available, so we just need to see how we can make that work from a capital point of view, which we do, and we'll continue to discuss that, and we'll keep you informed as we go forward. And it will probably form part of the new inpatient build in the first phase, or phase 1.5.
Yeah, thanks very much. And governors did get a briefing on some of the estate work and inpatient build before. Ted, and then Brian. Ted.
Oh, right. I didn't realise I raised my hand. Do you think that this current level of demand and supply and pressure is the new norm? And do you think the new Labour government will give you the money and resources to make it easier?
Well, that's a particularly difficult question to answer, Ted, to be honest. I'm not getting into the political dynamics. As we know, the resource from the recent budget, the NHS did get a little bit more funding a bit more resource into the baseline. We aren't expecting particularly any more resources at this stage. Obviously, there's a comprehensive spending review coming up later in the year, so we'll need to see where that takes us. We haven't got the planning guidance yet, and Pete will touch on that later, which specifies the resources available. We know that the NHS and the 42 ICBs are all under pressure around the system, but at the moment we are working within the resources that we've got, and that is the directive that we've been given, both by region, both by the central team and by the government, that we work within the resources that we've got, and we need to do more reform and transformation along those 3 lines which we've talked about before, which is analog to digital, treatment to prevention, and inpatients to community. So that's the specification that we're working with at the moment.
Doesn't sound very optimistic.
Pardon?
It doesn't sound very optimistic for the public at large.
Well, we do need to do some work around capacity. We do need to do some work around how we utilise the NHS and what we've got as well across the patch.
But I mean, that's only tinkering around the edges. Yeah. That's not going to be a fundamental transformation that everybody can get every service that they want at any time. So people maybe need to be educated to understand the limitations of the system.
Yeah. There is that aspect. I mean, the disappointing thing at the moment is no double running. So when you talk about transformation, it's always better if you have some double running information in order to move money around the system. There isn't. So we do need to look at using digital in a more innovative way and how we can move our resource around the system a bit more.
Thank you. Brian?
Hello, mine's about the new maternity mental health service as well, and I was very pleased to read the report on this, and it's a great innovation. What my suggestion is, I wonder if we could add another inclusion criteria, and that would be women who experience hyperemesis gravidarum. And I know they are not excluded from the service, but I think there's probably 3 reasons why the inclusion of them would be a benefit to everybody. First of all, they are a minority group of women, and where the service at the moment is very inadequate, and all women who experience hyperemesis have some kind of psychopathology.
Could you explain that a bit more for everybody, Brian?
What, hyperemesis gravidarum, or
yeah?
That hyperemesis gravidarum is a condition that affects about 1 in 100 women, and it's extreme nausea and vomiting that leads to dehydration and usually admission to hospital. So it's that extreme end of nausea and vomiting in pregnancy. And for about 1/3 of women, it carries on for the first trimester, another 1/3 for 2 trimesters, and the unfortunate 1/3 for the whole 3 trimesters. So it's a very serious condition for women affected, and they have very poor mental health, both short term and often long term, because it's like a trauma as well.
Okay, thank you. I think that's just helpful for everybody on the meeting. Thank you. I think Princess of Wales had issues around her first trimester.
She did, yes.
Thank you for that. And thank you for that, Brian. Obviously, we will have standardised operating policies and procedures and criteria. And actually, as a midwife, that was described perfectly. In relationship to hyperemesis, and I understand the difficulties that women do have in relationship to that through any of the trimesters, which is obviously the 3 stages of pregnancy. So yes, we will take that into consideration in relation to the criteria that we start to look at.
Yeah,
thanks,
I think it would be also useful for primary staff, for primary and secondary care staff in other settings, to know that there is a service there that will cater for these women, because again, people are floundering a bit with how to help women in this situation.
Thanks, Brian. Isabel.
Hi, thanks. Thanks, Michelle. It was sorry, my camera's not come on. It will do. Yeah, it was the issue around the clinical supervision for doctors and psychology placements. And in your report, there was a bit about how the situation was precarious at the moment in terms of the number of placements that the trust was supporting. And I know that there was an item, I think it's in the People and OD Committee paper, but I think Dean's not here today, is he? Saying that we've got a huge increase in the number of placements that are being supported, and it was just that statement about it being precarious. And if that's able to be managed and if that's an issue of concern for the organisation.
I think it's a really good question, and I think it always is an area of concern for the organisation, because it's one of those that we've go through peaks and troughs in relationship to placements and clinical placements. It's one of those that we get adequate, and then either the placements dry up and we lose that particular provider, or we lose that particular area, or we get a bit of an overcapacity issue. So I think if you'd asked me this time last year, I would have said it was okay, we've got plenty of placements, but we've lost some of the placements, so it becomes a little bit more precarious this year. So it's always been one of those things, especially when we do that clinical supervision audit and we are audited in relationship to it, that we always are on the edge of suitable placements for people. So it's one that we're constantly working hard with. So I won't say it's a particularly major concern, but it's always something that we're a bit anxious about in order to do that. But it's a lot better than it has been over the last few years, to be honest.
So the issue was that we didn't have enough people, not that we had too many, right?
Yeah,
makes sense. Yeah, thank you.
Thanks very much, Isabel. I haven't got any other questions there. I'm going to move on to the NEDS reports, because I know Phil has joined us because he had a conflict today. And maybe just questions to Phil about his report. Stuart, were you okay for the rest of the meeting today? I think you're all right, aren't you? Perfect. So Phil, are you there?
I am, yes.
Brilliant. He's had a fire alarm go off where he has been. So you're back in the building, are you, Phil?
They've let us back into the building now.
Okay. So Phil, if you could just sort of speak to your two assurance reports.
Yes.
We'll take questions, and then I'm going to take a comfort break for everybody, if that's okay. Phil.
Yeah, so we've had two meetings. There's assurance reports are in the agenda items. That was September and November. September is an extra meeting that we hold to try to get through quite a lot of the annual reports, and it's a really useful meeting because it gives a real sense of the breadth and the quality of work, and also the breadth and quality of assurance. And so in that, there's quite a number of annual reports there for interest. In November, again, back to more of a normal meeting, there was an annual update on psychology, which wasn't sort of full annual report due to sort of senior staff not being imposed, but gave us a real good overview of what the input of psychology into the trust. We've had those now for 2 years. We have starting to push to get a little bit more outcome information around the so what. So it's good to hear the input that psychology has, but to date we haven't really seen any information about the so what. So what difference does that make? Also in that meeting there was good items that helped us understand that the trust is a good learning organisation. So there was Nottinghamshire CQC report that's coming out in stages, but at each stage we've been having a discussion to see what our trust is taking from that report, and particularly around issues about community outreach. And then also there was a National Patient Safety Report, which looks at our move towards a significantly different way of looking at incidents in where the focus is, again, the so what for the trust. How can we improve our services and what have we learned? So really good meetings and really giving us strong assurance. And just to reinforce that when we don't get assurance, that the committee pushes back, but we're usually very well assured.
Thanks, Phil. Any questions to Phil or comments on his report? Just raise your hand. Okay, I can't see anyone. Thanks very much, Phil. Dean, as I said, is on annual leave. Are there any questions to Dean's report that we can have on the record, and then we'll follow that up? Anybody? No? Okay. In that case, we will go on to, let me get my order of papers right here. I think the next person is Steph. over to you.
Thank you.
Thank you.
There was this meeting on the 7th of November, which was my first meeting of the Mental Health Legislation Committee. So few focus areas, some positive reassurance around reducing restrictive interventions, which is the use of restraint, seclusion, etc. So really good work there within the trust, really encouraging. And that goes alongside training on de-escalation management and the Safe Wards initiative as well. So that's very encouraging. We did have a look at the 6-monthly MAPA report, and we also had a really useful presentation by our lead for Hull Approved Mental Health Practitioner Service on prevention, not detention, which was really interesting. Nothing really of note on the facts and figures with respect to Mental Health Act, other than to say at the moment we don't have any delays in patients who are clinically ready for discharge. Of interest for our next meeting, we're going to be focusing on crisis intervention. So we're going to be having a look at section 136 and measures taken within the trust and partners to look at reducing the number of section 136 detentions, which is the power of police to detain people who are in mental health crisis. We're also going to be having a closer look next time at community treatment orders, which are going to feature in the new Mental Health Act legislation. And we've got a fairly low level of utilisation of them, but we wanted to take a bit more of a look on what's happening there, what the potential is, and what the policy issues are going to be moving forward with community treatment orders. But other than that, any questions, I'd be happy to answer.
Any questions to Steph? No, thank you very much. Right, I suggest before we have Stuart and Keith might want to add something, we take a 5-minute comfort break and come back. It's 14:48, so back at 14:53, please. And James, if you could stop streaming and we'll come back shortly. Okay, welcome back to Humber's Council of Governors meeting. We'll pick up where we left off and go over to Stuart and your assurance reports, please, Stuart.
Thank you very much. Good afternoon, everyone. Welcome back to the part 2 of the meeting. I'm going to just introduce very briefly the report on the Audit Committee from late October. Once again, a very positive set of conclusions from that committee. I'm going to bring out just 3 things. One is that in terms of the feedback we get from our audit colleagues in internal and external audit and in counter fraud, there continues to be good evidence that our trust takes very seriously the questions of how to maintain the control regime and how to respond to audit findings in a positive way. And we've got some really good assurance from those sources that is still the case, which is very good. I think in terms of our culture, so a culture of kind of openness to challenge and openness to keep improving. Secondly, once again, we spent quite a bit of time looking at the business assurance framework, so the way in which our assessment of risk, our track record on performance, how they link to each other, and how we got the right balance of judgment about kind of some of the headwinds that we're facing, and are we reporting those things appropriately. As ever, we made some comments back to the team, which will just continue to feed through next month's reporting when we meet in February. The other thing I wanted to bring to your attention is that we always have a look at the corporate level, so the trust level risk register, and in October the 3 salient risks above kind of the score of 15 related to, once again, consultant vacancies and recruitment, money, so both capital and revenue funding for future investment. And we spent a bit of time thinking about the question of the waiting times for neurodiversity services. So just picking out those 3 things against the backdrop of a very positive set of reports coming through in October. And I'll just pause there for any questions on the Audit Committee.
Any questions? No, let's go on to the Collaborative Committee then, please, Stuart. Thank you.
Yeah, so you've heard quite a lot from Becky earlier in this meeting about one aspect of the specialist provider collaborative services that we look at. Again, I'll pick out 3 things. On the quality side, all of the providers within the network have routine monitoring status, which means that there are no salient concerns being really addressed critically at the moment. So that, and I feel that the reporting in terms of quality is very strong, it's very structured, and the level of oversight is very consistent. At the time of this report, across all the 3 work streams, the risks were 9 or below. We have had a meeting since this report, which was in October. We had a meeting in December. That continued to be the case in terms of those risks, and we did quiz at the last meeting service managers about whether that risk assessment was appropriate or not. So we provided some challenge back there, and I think we'll see another iteration coming through the risk assessment. And then a couple of things I wanted to bring out. One is that we've got some really good evidence about the intervention that we've made in eating disorders in young people to try and prevent admission into a setting, so early intervention, and we're now understanding how those learnings can be rolled out into the adult group as well. And then finally, echoing my question to Becky earlier in the meeting, we're identifying the cost of supporting patients who are ready for discharge to their next setting but aren't able to do that yet. And still, that's an ongoing piece of work where we're kind of slow. Progress is a bit slow, so we really want to work with our system partners on how to move people to the next setting, which is better for them and more cost effective from the taxpayer public purse point of view. So that's a flavour of the sort of things that are being looked at in the specialised provider collaborative at the moment.
Thanks very much, Stuart. Any questions to Stuart? That last point in some ways picks up on Ted's point earlier about how we use our money.
Yeah, very much so.
Okay, thanks very much. Then we will move on then to hear from Emma our partner governor, our appointed governor, obviously Emma works for mine, but she obviously through voluntary sector involvement brings that insight and knowledge and understanding. And this is an opportunity just to hear from you, Emma, a bit about obviously the voluntary sector and how Humber works with that sector. And I think it'd be really interesting for governors to hear from you. Thanks, Emma.
No problem. I have focused more on Mind and what we do with the trust. So, yeah, for anybody that doesn't know me, I'm Emma Dallymore, Chief Executive at Hull and East Yorkshire Mind, and a bit about our charity. So we've been going for around 50 years. We're an independent charity, but we are affiliated to National Mind, and that's why we can use the branding. And that gives me access to other minds across the country. There are around 100 minds in the country, and we sit in the top sort of 5 in terms of size. And as well as a charity, we're also a housing association. So we have about 125 bed spaces that we use. And we also have a subsidiary, which is regulated by CQC. And that allows us to work with people with more complex mental health. We support around 25,000 people every year, and we have a range of support, so from groups to one-to-one to housing for adults, children and young people. We employ over 250 staff, and partnership and collaboration really have been key to our success and how we work. So I work really closely with other voluntary sector organisations in the area, and with the trusts and with the local authorities. So in terms of working with the trust, we have really developed our relationship, I believe, over the last sort of 5 years. We've become a key partner for the trust. We can be very agile as a charity. We don't have that same red tape. We can move quickly and implement services quickly to help people. And one of the services that we have is the mental health support line. So it's what was known as the crisis line before. We took that on in 2020. And that's a 24/7 line. We have 4 people during the day answering the calls to that, and we take over 100 calls every single day. We have access, we run it from our building, but the trust has put their IT infrastructure into our building so that we can access their systems. So we can go onto Lorenzo, we can view patients, we can triage people, and we also have direct access to the crisis team so that we can discuss patients that might need further help or get advice from those clinical practitioners. It's a really important part of it that we can do that. We also have the crisis pad, which we run from our building on behalf of the trust, and that operates 7 days a week from 6 p.m. to 2 a.m. And we can take in 8 people every night in 2 sort of tranches of 4. And again, just to show how the sort of relationship has developed over the time, it used to be that the trust would have to refer people into that service. And even if we felt somebody was needing to go into the crisis pad, we still had to run it past the trust. But we don't anymore. We can do our own referrals, and you know the trust is there between us, between the 2 organisations. That means that we can allow people into the crisis pad without getting a second opinion. We also have short-term housing. We have 16 beds, and that is solely to avoid hospital admission, or for people that might be coming out of hospital that just need some time in some supported accommodation for up to a year. They can come into that service and we can help them with just being ready to live more independently. So we work with them over the year, and by the end of that, hopefully they can move into fully independent living. But if not, we have other housing that they can move into with a little bit less support. We have what's called a step down service, and that's a 5-bedroomed house. And that's for people coming out of hospital that need a short-term intervention. So they're ready to come out of hospital, but they're not quite ready to go and live somewhere on their own or even with support yet. And it's a bit more intensive. It can be for people that might not have a house, or the family's not ready for them to go back, and they can stay there for up to 4 weeks, where we'll work with them or we'll try and find them some other housing ready to go into. And we also have a peer support service, which we have 5 peer support workers in Hull. The trust has peer support workers in East Riding, so we do exactly the same, but we run the Hull service. And that's a really important service. That's people, the staff that we employ are people that have suffered with their mental health in the past. They might have had the hospital admissions, and they can use their journey to help other people. So for children, we work closely with CAMHS, and we have CWPs, children's wellbeing practitioners, the same as the trust has, and we can work with children around that. But we also have counselling for children in the East Riding. I think we see about 500 children per year with that service. And we have a children's safe space as well. So that's like the crisis pad, but for children. And again, we run that from our building, and children can come into that service from 8 p.m. until 9 a.m. the next day. We have shower facilities here. We have a washer and a dryer so that we can get them ready for the next day. And it runs until 9 a.m. because it's so that they can go straight to school. So if their home life isn't good, we can just take them straight to school from the service and let CAMHS know, and then everybody knows where this child is and what's happening with the child. I think we have challenges because we are running services for the NHS, but we don't always get the same uplifts that the NHS might get. So, for example, the national insurance increase, we as a charity, we're going to have to pay the national insurance increase, even though we run services to the NHS who isn't paying for that national insurance increase, but there's no further funding coming. So that's a real concern for us, because how do we as a charity keep going? So, we have to try and negotiate that elsewhere, or find other funding to enable us to carry on doing that. But that's not the trust. The trust is very understanding of what we're going through, and we do keep discussing it. But I know that there's nothing else that can come from the trust. It's a bigger issue than that. So yeah, that's all the services that we have. When I look around the voluntary sector, I work very closely with a charity that works with people from the Muslim community, and they've been working closely with the trust as well in terms of educating and making sure that people understand how different it can be for our Muslim communities. And the trust has been very involved with them, and they go in and do talks and just try and open up the space so that our community feel that they can attend the trust and attend us to talk about their mental health. So yes, that's everything that we do. Really, we have got some irons in the fire as well, I will say. So I think we've got 3 projects that we're kind of looking at taking forward and developing, but they're early stages, and sometimes they can take a couple of years to come into fruition. But yeah, we do have a really, really excellent relationship.
Thanks very much, Emma. And Lynn has put in the chat box about the work that's going on between us and yourselves and how it's really progressed. And Priyanka has said, what brilliant work, Emma. So glad to understand. So I can see Marilyn's hand up. Marilyn, over to you.
Hi, Emma. Congratulations on all the services that you provide. Just thinking about what you said about Muslim, how you interact with them. Anyway, I was just thinking, apparently there isn't a word in their language for mental health or breakdown or anything. So we found it when I was working in Bradford very, very difficult to entice people in. So to hear that you're actually going out and speaking to people, which is what we did, is a really good way of doing it. I think I think it's getting their confidence before they dare say things. So once you have their confidence, and it goes by word of mouth, then doesn't it? And so people feel they can come to you.
Yeah, definitely. And Mandy Dawley, I can never remember Mandy's job title, but Mandy Dawley at Humber, she talks to them all of the time, and they have a really strong relationship and partnership in terms of making sure that somebody's coming out to talk to them, and they actually work in our building. So anytime anybody comes in, we always show them around and explain everything that we do and our partnerships as well.
Great, thank you, Emma.
Thanks, Marilyn. Any other questions or comments for Emma? You put my hand up. No. Okay. Thanks, Emma. Thanks very much for sharing. Oh, Jackie. I've got Jackie.
I was dithering then. It was just the beginning bit, Emma. You know, when you're saying about representing the voluntary and charity sector, but it's such a difficult thing to do, isn't it? Because it's vast, and there's a lot of organisations in this space across the area that the trust covers. And I wondered if you'd had any ideas about how to do that, whether there are any key meetings or networks to feed into this one.
Yeah, it is really hard when you're the person that's representing the whole voluntary sector, and there are around 1,000 organisations. But we have voluntary sector assemblies, so it does get talked about a lot. And if there is anything that's raised, I'll always bring it back to the trust. I don't sit on it. So yeah, everybody that I know in the community, in the voluntary sector, knows that I have that relationship with the trust, and some others do as well, but they know that I'll raise things if I need to. So yeah.
And I guess that's our way back in as well from the trust, from this meeting. If we wanted to raise something in a wider space, it's the assembly.
Yeah, definitely. And yeah, it is. And with Lynn and Paul Johnson, we have done some other work. It was a year ago now, but we have done some other work trying to make sure that the trust is engaging with the voluntary sector. We had a mental health sort of partnership that was set up, and that's gone by the wayside for now, but it will come out again.
Priyanka's got a question in the chat box, which is about other communities accessing your services like South Asian communities, other than maybe the Pakistani Muslim community.
Yeah, so it's not easy. I'm not going to pretend that we're open to we think we're open. We think that our doors are open. We think that we're friendly, and we think that we're easy to access, but we're not always. So the Chinese community don't really access, the Nigerian community don't really access. They're some of our sort of bigger communities. I'm not sure about South Asian, but it's something we're very aware of. And as much as we say but we're available to everybody, if they don't feel that they can access us, then we're not available to everybody. So it's a piece of work that we're constantly looking at, but it is difficult. It's just not easy, but we do keep trying.
I think if any governors or also any board members have got some liaison or contacts, get in touch with you, Emma. Yeah,
absolutely. Yeah, that'd be great.
Brilliant. And Kimberly says, do the community groups MA meeting include VCSE child and young people services?
What's that?
I think that's victims of child sexual exploitation, Kim, you're referring to there. Have I got the acronym right for that, abbreviation right for that, Kim?
Sorry, I'm just getting over flu, so I keep choking. Sorry. No, it's they made like multi-agency meetings because you mentioned about having sector meetings.
Yeah.
But no, children and people services like children's charities.
Right. Sorry.
Mental health services. I work with those who are at risk of exploitation or at risk of youth justice services.
Yeah, we are really, really well connected across the system and across the area. So we're connecting with as many people as we can. What I won't do though is if I feel that something sits with another charity, we don't do that work. We will always try and pass it on to them, because there are other people that are experts, and we don't need all of it, but we can assist other people. So that's what we do quite a lot when we collaborate with people.
Okay, thanks. And Priyanka says her church has a large Nigerian community, so maybe there's a contact point there. Michelle.
Yeah, I was building on that Priyanka point and your point actually, Caroline. And first of all, thank you, Steph. I was just about to put the voluntary community and social enterprises. It's really good for that abbreviation. First of all, Emma, thank you for the work that you're doing, and I think it's really good that we are working so closely in partnership, and we'll continue to do that as we go forward and develop that. And I do think that we are a bit of an exemplar site for some of the work that we do together, and it's a bit about how can we measure those outcomes and publish those outcomes. But I know that you're on with that. No, it was just a bit of a plea really to the governors and to some of the non-execs really, just to say that if you have got any communities that you work with, particularly the governors as elected representation from your constituents, then this is a great bit of work to get involved with from an Emma point of view, so we can really look to see where some of our gaps are. And if we have got, for example, the Nigerian community or other aspects of your own populations that you're working with that feel that can be interact with Emma services, then just start to join the dots. And I think it's a really good presentation to do that and to demonstrate the importance of governors and how we can work with those constituencies and the wider community in the area. So thanks for that, Emma.
Thanks, Michelle. I think I might see if with Katie, when we're asking governors about their interests, maybe we could also ask them at the same time if they've got any networks, particularly within their areas of whatever type, that might be helpful as well for liaison and getting in touch. Thank you.
Sorry, Caroline, on that point, it's a really good point. It's something that we've asked the Engaging Members group to do as well before, and it might be something you want to take into there.
Yeah, which helpfully segues me into, thank you, Emma, that was brilliant. Appreciate that. We're going to move to item number 11, which is subgroup feedback, and there is the Engaging Members group note there for everybody. So Tony, do you want to just pick up on that? And
yeah, I just pick up on your point, Michelle. I think that's a really good point, and we'll pick it up at the for the next meeting. And Emma, I'll send you the details. Well, you've got the details, but let's try and have a discussion about that if we can at the next meeting. I say it's a very brief note. I think just the other thing to mention is that alongside the note is that, and this is since the last meeting, we're conscious of the, should I say, the low turnout for the number of members who voted for the new governors. So I think that's one of our needs to be our focus in this year and going forward, in what we can do to engage more with members, to encourage more members to vote, and also hopefully to encourage more members to think about being governors. So I think that's going to be one of our key priorities and focus this year.
Yeah, thank you, because we actually do a huge amount of emails to people. We had the membership cleanse, but also your individual contribution through your networks to get people to join up as members, but also take part is a really helpful part of that whole exercise as well. Brilliant. Any questions to Tony?
Thank you.
Thanks, Tony. Okay, thank you very much. We will move on then to governor's questions. I've got a question actually from Patrick Hargreaves. He's not with us today, but he did want to know whether the trust employed physician associates and how many. There's been a bit of press coverage, hasn't there, about this in the national press. Are there any, Michelle or anybody who can answer that question? Michelle, thank you.
Yeah, no, we don't, as it happens. We don't. Employing is a simple answer. Yes, there's been a lot of press about particular role, but no, we don't employ any at all. We do work with the university in relationship to those and some minor aspects of training, but we don't employ any.
Thanks very much, Michelle. And Marilyn, you did ask a question about impact of reorganisation of the ICS affecting Humber. Did you want to sort of add to that or raise that again here?
Yes, there's been a lot of news, and I've had a lot of things sent to me about the ICS and how difficult it's been for them, and that there are going to be a lot of changes made. And I just wondered how this is going to affect us, Michelle.
We haven't heard of any major reconfiguration changes yet. We've not been publicised with our organisation at all. Obviously, we've briefly touched on the work of the collaboratives, but that's all. So I know that the Integrated Care Organisation is looking at two aspects, which is about how provider collaboratives work closer with Place and the role of Place, which are the geographical areas, if you remember, the North East Links, the North Links, Hull, East Riding, North Yorkshire and York, and how they work closer together. But there's been, as far as I'm concerned, there hasn't been any particular consultation papers being produced. The ICB are looking to reduce their footprint of staff given the financial pressures, which we know about, and there has been a voluntary redundancy scheme that doesn't affect us. So at the moment, the implications for the ICB in those aspects is minimal and not affecting us at all.
Okay.
Thanks, Michelle.
Thank you, Michelle.
Thanks, Marilyn. Any other questions from governors? Okay, let's move on to finance report, Pete, and Keith's happy to take any questions or chip in on this as well. Pete.
Lovely, thanks, Caroline. I think we've got the performance report first, haven't we, Caroline?
Oh, sorry, performance report.
Yeah,
I'm
yeah, no
ahead.
problem.
Apologies
no
for
worries.
that. Apologies.
So this is some narrative on the latest performance for the Trust. You'll see in the paper we've included a link to the latest published board performance report. I mean, I'll take the paper as read, Caroline. The three things I would have pulled out is we continue to have really strong performance on our training compliance, you know, really positive on our vacancy rate, as you can see in the paper. And we know waiting times continues to be an area of focus that, you know, we discuss quite regularly at EMT. And I suspect that'll be a strong focus of the planning guidance and part of our conversations with commissioners as we get into the planning RAM. So I'll stop there and move straight to any questions.
So to allow people to gather themselves, I have a question from Tim Durkin that he sent in, and I think maybe you, Michelle, touched upon it earlier in your report. It's on the mandatory training. We are in the report at 94.2%, and our target is 85%, and the national average 88%. He's asking, shouldn't we be increasing the trust target to at least 88%?
I think, as I alluded to earlier on, Chair, we do have a conversation regularly at the executive management team about our targets levels, but we don't want to just keep raising them because we keep achieving them, because that's a bit demoralising for staff, to be fair. But the real reason is that obviously there isn't a national target. There isn't a national average either at the moment. It fluctuates too much. We are always above that, though. So Tim's got a really good point in relationship to that. And why don't we raise them? We're waiting. There's a piece of work ongoing at the moment around national statutory mandatory training. So we're looking at that. We set ourselves just above the CQC average, which is the really important bit, so that when we are reviewed by the CQC, we can say that we're exceeding their target levels, which is always positive. It's always better to overstate a target than understate a target and set yourself too high a standard. So we're waiting for some of the national work to be done, and we'll have another conversation later in the year in relationship to whether we should up the overall targets, because we do that. We do raise them, as we never lower them if we don't meet them, but we do raise them. So we'll take that into consideration, Caroline, and Tim's comments, and I know that he would be supportive of that. So we will have a look at that when we review it. The year that the work may not necessarily be out relatively quickly, so we might have to do our own thing. What we have done, it they mentioned at the board next time, is just signed a memorandum of understanding about transferring mandatory training across organisations, which is something that we've been wanting to do for a long time as an organisation. So that's positive. So we'll have, so basically no national target, no localised targets. We do benchmark very well. We will have a look at it on a regular basis. We'll take the governor's views into account and we'll feed back as due course as normal.
Brilliant, that's great. I think Tim's got a full answer there. I'm sure he'll watch it on the streamed event and it'll be in the minutes. Thank you. Any other questions on the performance report from governors? No? Okay, we'll move on to, I haven't missed anyone, have I? No. We'll move on to the finance report. Pete.
Thanks, Caroline. So again, this report takes us to the most public available data, which was October, which went to our board in November. I have included in the paper this time, for the first time with governors, some system context on the ICS financial position, because I think it's important to know the wider financial challenges across the ICS, and the risk there is within the wider financial position of Humber and North Yorkshire, which hopefully folk have read. I guess for me, if I was to highlight some of the summaries from the paper, as the trust, we recorded a small adverse variance at the end of October, and that related to the Agenda for Change Pay Award and the fact that that wasn't fully funded. But we have been working with the ICB and NHSA to come up to a resolution for that. Within the paper, we were reporting a break-even position, and we are continuing to do so. Within the paper, our cash position remains strong. It does fluctuate due to timing of payments on capital, PDC and other areas, but we've remained consistently above 23 million for the reporting period. And you'll see within the paper, our better payment practice code continues to be strong in the 90%. We do report value on the face of the report, but we do also report volume within the body of the report. And I know there's a question from Tim about a preference for volume to be in there, Caroline. And, I guess what I would say is I think value is still the key for me, speaking as a finance director, because I'd rather have 95% of the cash paid on time than 95% of the volume. But I'm more than happy to continue to include the volume. And just for assurance for the Council of Governors, the majority of non-NHS invoices that we don't pay on time tend to be agency and pharmacy invoices. So the larger firms that we deal with, where we often have queries on the invoices that we receive, and most of our smaller suppliers do get paid on time, which is what the BPPC was originally brought in for. So I'll stop there, Chair, and I'm happy to take any questions or if Keith wants to add anything.
Thanks very much. Let's just make sure that is it in the minutes that maybe to provide the minute taker with an answer on that one about the bills, so it's clear for Tim to see and pick up. Tony.
Hey, thanks for that. Just so on the finance report, just system, it's a system concept. It's not really about the trust. This, just so if I've understood this right. So the systems agreed a 50 million deficit, but the systems received a non-recurrent deficit support revenue allocation equal to 50 million deficit. So the system will get that if they break even. Is that correct? Or if we break even as a part of the system?
That's correct, Tony. So when the ICS agreed a 50 million plan, there was an allocation, I think it was around October time. So it has actually been received by the system now. So the system is expected to break even with the receipt of that 50 million. But as you can see from the paragraphs, that is still going to be a challenge between now and the end of the year, given the financial position.
Okay, thank you. I'm glad I'm not an accountant.
I won't wish it on anyone, Tony.
Pete, I've got. I'm today. I feel like I'm on Stars in Their Eyes. Today, I'm Tim Durkin as well as Caroline Flint. Forgive me if you did touch upon this just then, but about the issue around the paragraph 3.2, community and primary care, underspend, overspend. Can I read out Tim's question? And thank you. So this is Tim's question. I remain concerned about both the underspend and overspend. I suspect that the former relates to hard to fill vacancies. What assurance, please, can be given that human resources are giving some priority to filling these posts, that we can fully fulfil our commitment to community services, particularly in North Yorkshire? On the overspend, I remain of the view, Tim, that we should disengage from this provision.
So I guess splitting that into two, Caroline, we have a hard to recruit group. Lynn's on the call. I don't think North Yorkshire is particularly any more challenging than the rest of the trust. We have probably just benefited on that service on time, like for new services that have come online during the financial year. And I'm sure Lynn would want to comment if I've slightly got that wrong. And on the primary care, I guess, that's part of what the board would discuss under any planning round, isn't it?
Thanks very much. Michelle.
Yeah, I mean, it's a good question, but we did a big piece of work, if you remember, last year around primary care post, both from a general practitioner point of view as well as community, that involved the community staff and primary care staff themselves, saying about how good it was to work. And actually our figures have increased in relation to recruitment retention, specifically around GPs. So I wouldn't exactly say that they're necessarily hard to fill. Every post hard to fill in the NHS at the moment, but no more so than others. And certainly the January Unbelievable recruitment campaign has been really successful. So it's a good question, but I'm happy to take offline with them if that's preferred.
Okay, fine. Well, I think he'll be watching this and it'll be in the minutes, and when he comes back from being with his family on leave, he'll pick it up then. Any other questions on the finance report for Pete? Keith, is there anything you wanted to add?
I think Pete summarised it beautifully. I think we're in a reasonably good position. I think the pressure in the system is the biggest concern and the biggest worry, and will be for a while.
Okay, thank you. I'm holding back because I don't want to miss anyone. If anyone else wants to put their hand up. No, okay, we'll move then on to item 15, any other business. I haven't been notified of any other business. Review of the meeting. I am going to ask for the future agendas, actually, that we actually put in a few points about what this actually means, so that we know what we're looking for. So I've pulled out something else from another meeting, and so basically it's the questions are: has the Council of Governors focused on the right areas? Were the quality of the papers good enough to enable yourselves as governors to perform your role? Has it engaged people in discussion and exchange? Was the debate allowed to flow, and were all Council of Government members, Council of Governors members encouraged to contribute? And has the meeting been conducted in accordance with our behavioural standards and values, which is about being inclusive, about listening to what people have to say, and obviously communicating well with each other? So is there, laying out those points, do you feel we met the brief, so to speak, or is there anything else we should take away? Tony's giving me a thumbs up. Thanks, Tony. And John, thank you. As there's no thumbs down at this point, I might move on. Oh, and there's more thumbs up. Thank you so much for that. Appreciate it. Great, lovely, thank you. So that draws us to the conclusion of our meeting. There is an induction for new governors happening next week. I'm actually having one-to-ones at the moment with each of the new governors and having a chat with them. I think I'm sorry if there was a bit short notice to governors, because you're all welcome to join the induction session. It's in person and you're welcome to come along. I'm sure if there was some short notice about that. I included in the pack, in my report, a sort of forward look at the items for governor briefings and the governor development sessions. If governors have got any other ideas about some of the topics they'd like to hear about, please get in touch with Katie so we can assign them to a governor briefing or include them in the agenda for the sort of half-day governor development sessions as well. Or if required, we can always get a written note to governors as well. So it's all of the items I think on that outline that I've put in there, which includes some of the past topics we've done in previous sessions in 24, have pretty much been put forward as a result of your contributions and your interest. So without further ado, thank you all very much. The technology seems to have worked pretty much today, so that's all good as well. Have a great rest of the week. And to John, best wishes from all of us. In your, I know you're involved in lots of activities in your locality. All the best for the future, and see you all again soon. Thank you so much.